So what is hyperemia and congestion, students? It is the increased amount of blood in the dilated vessels. In dilated blood vessels, increased amount of blood is called as hyperemia and congestion. What are the differences between both of them? Much more theoretical, right? Hyperemia is an active process. Congestion is a passive process, right? Hyperemia is usually red in color. Why? Because of the presence of oxygenated blood. What kind of a blood is there? Oxygenated. Congestion is usually, the tissue is usually blue in color. Why? Because of more of deoxygenated blood. Because of more deoxygenated blood, it is much more congested, much more blue in color, right? Hyperemia is usually due to arteriolar dilatation. Congestion is usually due to impaired venous outflow, right? And what is an example? Where do you see hyperemia? Have you ever seen a tissue which is inflamed? Do we say rubor or redness? That is due to hyperemia, right? So in inflammation, there is hyperemia. That is an example. Whereas in right heart failure, there is congestion. That is another example, right? Now, what is important from this is basically the three images which I'm going to show you now. First of all is the image of heart failure cells. The first question which I want to ask you is, what are these heart failure cells? They are basically hemosiderin-laden macrophages. What are these, students? They are hemosiderin-laden macrophages. My next question, where do you see? They are seen in which organ? They are not seen in the heart, they are seen in the lungs. Why are they called heart failure cells? Because they are seen in patients with congestive heart failure, CHF. So I'm repeating the story once again. Heart failure cells are basically hemosiderin-laden macrophages seen in the lungs of a patient with CHF. So suppose they say that this is a lung biopsy of a patient who has a heart failure. You see some of these cells, right? What do they look like? Students, the answer is going to be heart failure cells. Why are they brownish in color? Can you people appreciate all these brownish cells? Why are they brownish in color? Because hemosiderin is golden yellow or golden brown in color. Remember? So what are these, students? These are heart failure cells. They have a deposition of pigment, that is hemosiderin. What is there? Which pigment is there, students? There is hemosiderin pigment which is there, right? Hemosiderin pigment is brown in color. So you can see all of these cells are brown in color, right? If I ask you another question, what is the special stain I will use to see the heart failure cells? What is the special stain for hemosiderin? Basics. Very good. The answer is Prussian blue or pearl stain. That is the stain for iron also. So that will be the stain for heart failure cells. Understood? This is a very important image for MCQ exams. Clear? Next. Very important, students. NEET and INICT have asked this image a lot of times. Whenever there is chronic venous congestion in the liver, CVC of liver produces a lesion which is called as Nutmeg Liver. Again, students, pathologists and their love for different food items. Have you ever seen nutmeg? That is a spices. Have you seen it? Looks like this. When we see a congested liver, right, it looks like this. Don't you think it looks like a nutmeg? This spices. That is why this is called as a nutmeg liver, CVC liver, right? So it has got two kinds of areas, as you can appreciate. We have a red area and we have got a pale area which is there in between. And this is called as a nutmeg liver. Done, students? Third image which is important is splenic image in congestion. When a patient has got congestive splenomegaly, it shows something which is called as the Gamna-Gandhi bodies. It shows something which is called as the Gamna-Gandhi bodies. What are these Gamna-Gandhi bodies? They are seen in congestive splenomegaly. Where do you see? Congestive splenomegaly. What are these bodies composed of? So they are composed of fibrosis. They have calcification. Can you see? Intense purplish areas which are there, right? Then they have got hemosiderin. Can you see the brownish pigment in between? See this brownish pigment? So the bodies have got hemosiderin, fibrosis, calcification. They are called as Gamma-Gandhi bodies. Gamma-Gandhi bodies. Done, students? Three very important images which you need to know from this module. Let's move to the next topic, that is called as thrombosis. Now, for thrombosis, students, a scientist called as Virchow, he gave a triad. He said that three things are required for thrombosis to happen. What are those three things? The first thing is called as endothelial injury. You all know that all our blood vessels are lined by vascular endothelium, endothelial cells. And a lot of things happen when there is endothelial injury, right? So, endothelial injury is one of the very important factors, he says, for the risk of thrombosis, development of thrombosis, right? If a patient has got hypertension, hyperlipidemia, or other disorders, it can lead to endothelial injury and there can be increased risk of thrombosis, right? The second one, he says, is abnormal blood flow. Now, you all know through a blood vessel, normally the blood flow is very smooth, and that is called as a laminar flow. Smooth flow, also called as laminar flow, right? What will happen? The problem will happen when there is either stasis or there is turbulence. If there is stasis or turbulence, what is stasis? If the blood flow is slowed down, there is slowing of blood flow. Or if there is turbulence, that is very, very rapid blood flow. What will happen? Because of this abnormal blood flow, it can lead to what? It can lead to increased risk of thrombosis. Correct? Lastly, hypercoagulability of blood. There are a lot of conditions in which our blood becomes hypercoagulable, right? And that is the other factor which can lead to increased risk of thrombosis. So, endothelial injury, abnormal blood flow, and hypercoagulability of blood, right? So, with this, we come to the topic that what are the causes of blood hypercoagulability? Very, very important. Or in other words, this is also called as thrombophilias. Thrombophilia, the causes of blood hypercoagulability. They have been divided into two categories, primary or genetic and secondary or acquired. Can you tell me what are the genetic causes? The first one is factor 5 Leiden mutation. Factor 5 Leiden mutation. Please remember MCQ, it is the most common primary cause of blood hypercoagulability. What is the most common primary cause, students? It is factor 5 Leiden mutation. Next, prothrombin gene mutation. Prothrombin gene mutation, right? Then protein C deficiency. Protein S deficiency, antithrombin 3 deficiency, right? Then the patient can have hyperhomocystinemia. Hyperhomocystinemia. These days, students, this is a very, very important risk factor for thrombosis, hyperhomocystinemia, and a lot of research is going on the risk of thrombosis when a patient has got hyperhomocystinemia, right? What are the secondary or acquired causes which are there? It can be pregnancy, oral contraceptive pills, right? If the patient has got prolonged surgery or prolonged immobilization, the patient is not mobile, prolonged immobilization, right? Then microangiopathic hemolytic anemias like HUS or TTP or DIC, all of them will predispose. APLA, antiphospholipid antibody syndrome. Then hyperhomocystinemia. Now, hyperhomocystinemia can be both due to a genetic cause, and if it is due to vitamin B12 deficiency, it can be a acquired cause of thrombophilia or hypercoagulability. Understood? Very important causes. Sometimes they can ask you a question, which of the following is not a risk factor for, or which it does not lead to a hypercoagulable state. So you have to mark any of the options except for these. Done? Okay. Then students, we have two different kind of thrombi. It can be an arterial thrombi or it can be a venous thrombi. Arterial thrombi usually develops in rapidly flowing arterial blood, of course, and In veins, you all know that the blood flows slowly. So venous thrombi usually develops in slow moving blood of veins, right? Then arterial thrombi usually develops in turbulence. Venous thrombi usually develops in stasis. A very important point that you have to note is that arterial thrombi propagates retrograde to the point of attachment. So if this is a vessel, this is the point of attachment, it will propagate retrograde. Whereas venous thrombi develops along the direction of blood flow. Whatever is the direction of blood flow, venous thrombi will develop, right? Grossly, arterial thrombi is white in color. Venous thrombi is red in color. This is white because it has more of platelets, and this is red because it has more of red blood cells, more RBCs and more platelets. Done, students, the difference between arterial and venous thrombi, right? Now, a very important another MCQ which is asked is lines of Zahn. It is seen that thrombi may have certain lines which are called as the lines of Zahn. This is an MCQ. If I ask you what are these lines of Zahn? In this thrombus, can you people appreciate there are alternatingly. There is a dark area and then you will see there is a light area. Then there is a dark area, then light area, then dark area, then light area. So there are alternate light and dark areas. What are lines of Zahn? They are alternate dark and light areas, right? Remember, students, the dark area is formed of RBCs and the light area is usually formed of platelets and fibrin. They are usually formed of platelets and fibrin. That's an MCQ. Dark area formed by RBCs and the light area formed by platelets and fibrin. Can you people appreciate there is darkish area, lightish area? Now, they are seen both in arterial and venous thrombi, but if you have to mark one better answer, they are better seen in arterial thrombi. They are better seen in arterial thrombi. Arterial thrombi. Understood, students? With this, we finish off with the topic of thrombus also. One extra thing which you need to know is what is the fate of a thrombus. What is a thrombus, students? Basically a mass of platelets, right? Now, what is the fate? For that, you have to remember the mnemonic DOPE. D for dissolution. A thrombus can dissolve. That is one of the best thing. O for organization. It can get organized, right? P for propagation, not good for the patient. There is propagation. And E for embolism. Embolism, again, not good for the patient. So the fate of a thrombus, you have to remember the mnemonic DOPE, dissolution, organization, propagation, and embolism. The last two are not good for the person or the patient. Understood, easy? Okay. Then we move to the next topic, students. That is also important because you can get some clinical scenarios from this topic. That is a embolism. First of all, you people tell me the definition. What do you mean by a embolus? Embolism or a embolus is a detached intravascular. It is a detached intravascular, solid, liquid, or gaseous mass. Solid, liquid, or gaseous mass which is carried by the bloodstream. It is carried by the bloodstream to a site which is distant from its original site. Distant from its original site. Understood? So basically, suppose this is a blood vessel. So basically a solid, liquid or gaseous mass, suppose this dislodges and gets impacted somewhere else. That is called as an embolism, right? Now, broadly speaking, there are different kinds of embolism that we have. The first one is called as a pulmonary embolism, pulmonary thromboembolism. If I ask you, what is the most common cause of pulmonary embolism, students? Answer is deep vein thrombosis. 95% of cases, the cause of pulmonary thromboembolism is DVT, deep vein thrombosis, right? That's an MCQ, right? Now, remember, students, most of the time, pulmonary embolism is asymptomatic. Why is it asymptomatic? Because my lung has got dual circulation. You all know that lung has got dual blood circulation, right? So that is why it is usually asymptomatic. But one kind of pulmonary embolism, which is bad, is called as the saddle embolism. In this image, you can see this is called as the saddle embolism, and this saddle embolism can lead to SCD, sudden cardiac death. What is saddle embolism? This is present at the at the bifurcation of vasculature, of pulmonary vasculature, and that is called as a pulmonary embolism. Can you see? This is present at the bifurcation. This can lead to sudden cardiac death, and that is why, students, this is the dangerous embolism. It is called a saddle embolism, right? Otherwise, most of the time it is asymptomatic. Clear? Okay. Then, students, the next one which we have is fat embolism. This is important, and you can get a clinico-pathologic scenario on this. Now, understand this, students. While I was doing my internship in Safdarjung Hospital, I saw 2 or 3 patients in the surgery and the orthopedic wards. Now, the patient had got long bone fractures like femur and tibia, right? What I saw was that today, if I was examining the patient, the platelet count was normal and the patient was normal, right? But after 2 days, when I went and we sent the investigations, I saw that there was a sudden diminution of the platelet count. Also, I saw that the patient was in some kind of delirium. There were some petechial rashes on the body, right? Then I asked the surgeon and the orthopedics PG postgraduate that what is this? What is the problem with the patient? And they told me that this scenario is called as fat embolism, right? So usually when does fat embolism happen? The first point is it usually happens in long bone fractures. Long bone fractures. If my patient has got long bone fractures like femur or tibia, what will happen, students? There will be fat embolism, right? Now, what is this and why will it happen, right? So, you all know that bone has also got fat. Marrow contains fat, right? So, those fat globules will get impacted in the various organs, and that will lead to fat embolism, right? Also, those fat globules will attract the platelet towards itself. When the platelet sticks to it, what it will lead to? Thrombocytopenia. Understood? So, what I used to see, students, is 1 to 3 days after fracture, the patient develops. What are the symptoms the patient can develop? The patient can develop delirium. The patient can develop dyspnea, petechiae, and there is decreased platelet count, thrombocytopenia. I've told you the reason why. Because platelet will get stuck to the fat globules, right? So when I see such a scenario, you will start thinking, oh, this patient has developed fat embolism. Understood? So on urine microscopy, in this case, what do I see? I see fat globules. I see a lot of these fat globules. Understood? That is also an MCQ. So this is a clinical scenario which can be asked in your exam. Next, the next type of embolism is also called as air embolism. It is also called as air embolism. Now, what is air embolism, students? It is also known as decompression sickness, or it is also known as Caisson's disease. It is called as Caisson's disease or decompression sickness. Very important point, right? Now, where do you see this air embolism? Can you people appreciate what is happening here? This is a deep sea divers. So, it is usually seen in deep sea divers or scuba divers. Deep sea divers or scuba divers. Why? Because of sudden change in atmospheric pressure. What will happen, students? There is sudden change in atmospheric pressure. When there is sudden change in atmospheric pressure, what it will lead to? It will lead to the formation of nitrogen bubbles. And when these bubbles go in the vessels, they will cause air embolism, right? So it is seen in deep sea divers or scuba divers. Why? Because there is a sudden change in atmospheric pressure, which will lead to the formation of nitrogen bubbles, which will get impacted in the vessels and will lead to air embolism. Understood? Easy story till now? Okay. Now, this disease will clinically manifest in two forms, either bends or chokes. What is bend, students? When these bubbles get impacted in the joints. So the patient can have some joint pain, due to which the patient bends his joints and then walks. Or chokes is basically when these bubbles get impacted in the lungs. The patient can have breathing difficulties. Correct? Now, another MCQ which you need to know from this is that more than 100 ml air, cc of air, is required for the development of air embolism. For air embolism to happen, more than 100 cc of air is required. That is a very, very important MCQ. Done? Clear? This is about air embolism. The last type of embolism that we have is called as amniotic fluid embolism. Of course, students, where will this develop? Where do you see the amniotic fluid? I see it when the female is pregnant. So this is usually seen as a pregnancy complication, or it is usually seen in the postpartum period. As a pregnancy complication or in the postpartum period, you will see amniotic fluid embolism, right? Now, what happens, students? There is a tear in the placental membrane. There happens a tear in the placental membrane, and through this tear, what will happen, students? The fetal tissue will enter the maternal circulation. Fetal tissue enters the maternal circulation, and when it enters the maternal circulation, what do you see on microscopy, students? So if I say take a sample, I can see squamous epithelial cells, whorls of these squamous epithelial cells. I can see lanugo here, right? Vernix caseosa and all. And when I see them, I start thinking, okay, this is amniotic fluid embolism. In this image, can you people appreciate these? These are basically the whorls of squamous epithelial cells. These are the whorls of squamous epithelial cells. Understood? With this, we finish off with the topic of embolism also. Let me tell you the clinical case scenarios for all of them. First of all, pulmonary embolism, the most common cause, deep vein thrombosis. If my patient has got fracture of long bones and after 1 to 3 days the patient develops thrombocytopenia or dyspnea, think about a fat embolism. If it is given that the patient is a deep sea diver or a scuba diver or flying up high in the air, the patient has got lung problem or joint problem, you think about air embolism. If my patient is given as pregnant and there is a microscopic slide which is showing some squamous epithelial cells or some hair, you think about amniotic fluid embolism. Understood?